So the one that I read was, do corticosteroids still have a place in the treatment of chronic pain? And basically what it came out to was yes. Obviously it just depends. Because most like the warnings are mainly like for the FDA like effects where it has like stroke and like paresthesia and things like that, but those are looking at certain corticosteroids that are like either like not what is it? I wrote it down where it's like more towards the transforaminal injections and the particulate steroids, which are like you need more injections for, and they're not as soluble. And they're not looking at the like other less invasive corticosteroid treatments. So a lot of the ones that are looking at less invasive ones do have good effects, and they've even shown to be up to 6 months, but it's also in conjunction with like a local anesthetic. So alone it has benefits, but there's increased benefits when you like use like a combination of either like physical therapy or local anesthetics to increase those effects. So that's what I found. But yeah, briefly, I don't know what y'all want to say about it. I mean, just want to get a little gist.
Did it talk about the any adverse effects, or were they just focusing on does it do good for pain or not?
I mean, it talks about adverse effects, um, more like where, what was it? What he said. Mm, I mean, the adverse effects it talks about were like, yeah, just the FDA label warnings, but I feel like that's with anything.
Oh
But then
yeah.
they talked about like with pain wise, they say that it's usually beneficial and you just have to kind of look at the patient as a whole and see if those adverse effects outweigh because most of those effects are like you get like rashes or hives, but then you just or hives are like allergic reactions, but then you can either like, change the injection, like how you give it, like make it not topical, like more local anesthetics are, or making it more site-based. We talked about it's like you need to be more concise with where you're injecting it rather than just like general pain relief because it needs like a specific site to act on that has like the best benefits and like the least amount of adverse effects. I don't know if that made sense. I just kind of like word vomited, but
No, it makes a lot of sense because like I get the transforaminal injections and they work. Now, what I've been told is that like in most people it works for that 6 month range, but that's like normally older people. So like my injections work for a year and they're number one, very surprised by that, but number two, they put that towards the fact that I'm younger and a little bit more active than like an 80-year-old with my condition.
Mhm.
So I think that's interesting.
Yeah. And that like reminded me of like, what you were saying, like up to like some of them, depending on like the like for like with local anesthetics and steroids, like what you were saying, how only up to 6 months it has like a benefit and then it kind of just either tapers off. It showed a lot in that. And then where was I going with that? Because I was like, because I thought that was really interesting. Um, damn. Oh, because I mainly, sorry, we looked at it like in secondary like conditions. So it was like radiculitis or radiculopathy secondary to this condition. So it didn't really look at like primary like like those types of arthritic conditions. Like it looked at like, oh, this helps with like secondary type of conditions. I thought that was interesting. So I was like, not the primary, but okay.
And
And I
that
guess
was,
this is why like older populations, maybe that's why it benefits older populations more because they're so much older, so they could develop those secondary conditions compared to like younger people versus like the primary, I guess. But what were you saying, Cassie? Sorry.
well, I was just gonna say that's just nice to know, good information to know in general though, is that because then if you have like a primary condition, then you're probably not worried about even looking into this at all, period, for pain relief until it becomes something else. So it's like, well, I can try these other things instead. And then if it develops, then I only have to worry about this occasionally. Like you're not going to need it as often as you're going to need the treatment for the other stuff,
Mhm.
if that makes sense. So the adverse effects then to become even less important because you're not getting it as often, so it's not going to affect you as much.
Yeah. And there was even one, I hope it's like right, where it even showed that I think it's the particulate versus like the non-particulate, so like the fat soluble versus the non-fat soluble. I want to say like, oh yes, I found it, thank God. Where the no, I didn't. No, I did. So the particulate ones that are not soluble, like poorly soluble, so they're not very good at breaking down. They have a longer duration of action and they require fewer repeated injections, but then those are the ones that have like a higher risk. And the ones that are non-particulate, which are easily more soluble, they need more injections since they are being like broken down easier. But those ones have less adverse effects. Like you're saying, like it's at least we can weigh out like, oh, if the secondary condition, how much we want to weigh out this risk of like pain management, like pain relief. But yeah, I just want to add on to that 'cause I thought that was interesting. I didn't know that there were different types of those types of steroids.
Yeah. I think it's
Mm.
worth it for the most part. Like,
Yeah, I feel like it is it's worth a shot for sure, especially if you tried so many other ways. Like you're saying, like you might as well try this.
get it, worth a shot.
Shut up. Anyway, okay, Brian. Anyway. Mm,
Uh,
but I guess I will add is that I think even to add on to what Jack's saying, that it even is proven that these are just more for like short-term relief. So yeah, if we're doing like pain management, I guess it's good to like kind of mediate that pain so you can find like a physical therapy that helps or like a different type of pain management. So it's kind of like a buffer period, like, oh, we can apply this not as like a long-term pain relief forever, but I mean for like our first 3 or 6 months just to help them function at least for a little bit.
yeah. Well, and part of the reason I asked about like the adverse effects is because the article that I read was about the risks and benefits of the glucocorticoid treatment. And I mean, this was specifically like about tendinopathy, and majority of the article was conflicting because I think they were trying really hard not to be like biased when they were talking about the article. But like overall, when you look at like the facts that are in the article, it says that like it's not good, like that you shouldn't take them because it does like harm to specifically like when it comes to like scarring and the healing process. Basically, that when you get the injections, it's slowing the healing process down, causing like collagen necrosis, like it makes scar tissue not heal correctly and like take longer, can increase inflammation and stuff like that. But like, yeah, it does its job. But so that's why I was asking about like the adverse effects on your end because I didn't know if it mentioned it. Because that's all that mine was about was just like, is it worth it or is it not?
Mhm.
But they did mention the whole old people thing that Angelica was talking about because they were like, well, for somebody that's older who like is gonna have the pain anyways and probably already has like all these adverse healing effects and at like from other issues that they're having, then like they might as well do it. But like if you're going to be consistently getting these injections as like a younger person, then it's probably better to like find, like you said, like find an alternative route of medication or pain relief.
It's kind of like the opposite of my article. So I mean like so gnats is the opposite of
Uh,
cassid. Like mine was kind of like, okay, so what do these corticosteroids do for pain relief when it comes to rotator cuff tendinosis? And they kind of classified it as like basically everything. So impingement, fraying of the rotator cuff, partial thickness tears, tendonitis, all of that. They were all like, that's tendinosis. That's what we're calling it. But they're all very different injuries, right? So I did not like my article in that sense because you're looking at something that they're all completely different. You're basically just looking at what the story does for the shoulder, which in a sense is helpful, but in another sense, it's like, what the heck? Um, and it basically was like there's no pain difference within the patients when it comes to like placebo and getting the actual corticosteroid injection. Like when it comes to the first month and this and the third month, there were no changes in the VAS pain score, like at all. None. But then in the 2 month assessment, there was like a slight and transient pain relief. But then it's like, man, okay, it's not really changing anything at all. So my article kind of took it as like, okay, so then do the risks really outweigh the benefits if they're really not getting any pain relief with this injection to this area, but they're also have at risk of having this injection deteriorate their tendons.
all the mechanical stuff. Yeah, mine touched on that too, that it can worsen the mechanical or like increase mechanical failure if they take it more often. Which I think is what Matt talks about a lot too in the clinic, especially with his baseball boys, where he's like, yeah, you could get that, but like just letting you know, like it's gonna increase your chances of like tendon injury if we make this like a regular thing. Like I feel like I've heard him say that a lot to like those baseball kids at TLU.
Yeah. And then it kind of looked at like doing multiple injections instead of just doing one singular injection. And it was kind of like they're not doing anything. So why continuously put this injection into your body if it's going to have the same effect as one injection? Because at that point, you're really just harming yourself more than you're doing any good for yourself. And I think, well, not I think, well, I think, but then like this article also thinks that um, instead of using this quick fix that physicians do use, to instead maybe think about it just for a second and see, oh, maybe let's not just jump straight into doing a steroid shot.
Yeah, I agree. Mine looked a lot at like but like combining it because I think it like talks about how like what y'all are saying how I think those are those negative effects, but then it like focus on like how to like maybe like a combination that targets both like that idea of like the duration and then also just the efficacy, like because it may help, but like you're saying, like it degenerates the area, like the bone and like the muscle tendon, everything like that. So I think that's why like it talked about combining like either like the PRP or talked about like just like the local anesthetic. So like I think maybe lessen the amount of steroid they give while still because there's like benefits to it and they know that there are benefits, but just I guess alone maybe it's just too intense and why that's why there's like in mine I was talking more about like combining it like because it talked about having it alone and it still is effective but like it showed that there's just increased like functional and like long-term outcomes I guess with combining it with something else like another medication not just like physical therapy but also like a medication things
Yeah.
like that.
Yeah. I think Angelica and I are more similar.
Mhm.
I don't know. I think they
Smart.
all make sense though. Like I feel like it's sounds fucked up to say common sense because it's probably not common sense, but like just from what we've heard, I feel like from like Matt and from like previous classes, it's like, well, yeah, no duh, it causes injury, but also, yeah, no duh, are we gonna do that more often on like older patients? Or like my article even mentions like patients that are like surgical candidates. They're more likely to do it on them rather than like people that don't need the surgery because they're already gonna go in here and like cause a bunch of harm to the surgical site. So like injecting it with a corticosteroid beforehand isn't gonna really make that much of a difference. Um, so it's like, yeah, of course, no duh. Like, of course, I'm gonna do it to them rather than a 12-year-old that just tore his rotator cuff. Like, I don't
You
know.
see mine touched on like the surgery part but in comparing like the because when they talked about surgery, they were like, "Oh, we're gonna look at this group and this group, and we're gonna do the corticosteroids for this group, and then placebo for this group, and then we're gonna ask them at the end or assess them and see which one rather be more likely to benefit from surgery." And it showed that like people with the corticosteroids, mainly the combination ones, were less likely to get surgery. So I don't know. I guess I don't know why my article's so different, but mine was talking about how like it decreased the need for surgery, or at least delayed it longer than people who then felt like they needed it when they didn't have anything. But I don't know if that's like the idea of just getting treatment. They're like, oh, I don't need surgery, but they still actually like maybe need it just as much, but they think because they're getting a treatment, they don't need it. Maybe that's what it is.
I don't know, because
Um,
mine basically says like they like it's basically like it makes sense for like from a clinical like gain over risk standpoint for people who are not suitable for surgery. So it's interesting that your article looked at people that were supposed to have surgery and then like used it and then would have been fine without it because then it's like, okay, well then that makes sense what my article said about like, okay, we should just give it to the people who aren't gonna have surgery anyways, just to get rid of the pain.
yeah.
But then that like also kind of contradicts my article specific to shoulders, where it's like, okay, it's not doing anything. Like it's not
Yeah.
limiting pain. Does that make sense?
Yeah.
Hmm. Did yours look at a specific tendon, Cassie, or just general?
No,
Like,
mine was all general. I'm sure they did. I'm gonna be real honest. Mine was like one of the analyses,
um,
analysis, whatever.
mhm, mhm, mhm.
So I literally like put in my little notes. I was like, not gonna lie, I always skip most of this stuff when it came to the methods of like what they chose.
That's
But
valid. Valid.
the one thing about mine was that most of mine, there were 36 animal studies and 13 human studies. But both like sets of studies, animal and human, had a mixture of like living people, like living studies, and then like car like what do you call it? Like the cadaver studies, where they like looked at animals or people that were alive versus injecting it to animal and people that were dead. Um,
Hmm,
and then there was one that was like a combined, they did it on both humans and animals, which was really weird. And they did it on an embryo also in like multiple studies. There was a chick embryo. Don't know how you're testing that on tendons, but I wasn't gonna question it because I don't know anything about chick embryos. So I'm not really like, it doesn't specify if any of them even looked at
interesting.
a specific
Mhm.
one. Most of the ones that they were looking at were like at a cellular level. It's looking at like how did it affect collagen? How did it infect inflammatory cells? How did it infect fibroblasts? And then um like the toxicity levels within like the blood basically. And overall, like it gives obviously like specific numbers where it's like this many studies found this many studies found this many studies found this or whatever. But their overall consensus was that collagen became less organized and there was less collagen synthesis, but more collagen necrosis. Fibroblasts decreased proliferate. Oh my gosh, I can't speak. Fibroblasts decreased proliferation and viability, but then inflammatory cells were increased and toxicity was increased. So like it sounds really, really bad when they just like list it out like that. But then at the same time, there were um 6 studies that showed a decrease in mechanical properties. 3 studies showed an increase in mechanical properties, and then 9 studies showed absolutely no change in mechanical properties. So it was like, okay, you just told me all this crap about how like all the cells were kind of like went crazy and berserk, and like it sounds like really, really bad. But now you're telling me that majority of the studies show that there was no change in like the ability of the tendon to do its job. So in reality, like we still don't, to me, it's like, okay, well, we still don't have an answer about whether or not it's good or bad. But then like the conclusion of the article is like, it's generically bad, is literally what it says. And I was like, okay.
And I got a lot of generally this is used, generally this would be good. Or then I got then like the same thing with you would be like, yeah, but it was significantly like insignificant, but like it did have this percentage, and I'm like, I feel like you're trying to tell me it's significant, but then you say it's not significant, but then you use this big number of a percentage that makes me think that I feel like this might be significant, but if you're telling me it's not, you're obviously the article, so.
Yeah.
But also then I'm wondering if like a lot of the studies are done in like older populations where they get that injection and they don't move. Because then mine was talking about how like there's benefit and it did have older populations, but it showed like with physical therapy and like movement and being active, it like decreased that like breaking down of bone and those types of things. So I'm wondering if a lot of these are because like older populations they just like obviously can't move as well, so they're not.
Yeah.
I guess I don't know, like utilizing the steroid to its fullest. I don't know. You know what I
Well,
mean?
then like after, so like working at the PT clinic, I saw like multiple like older people that would come in after like total knee replacement or something. And they had like 2 weeks of like home PT with like the home care people. And like every single PT that like was doing their eval on them and was like, oh, you did home care for 2 weeks, like noticed like drastic like decreases. Like they came in and they had started out so far behind compared to everybody else. So like that's just proof that like they're probably also not getting the same treatment and care like as a younger person would after getting a surgery like that. Like especially a younger athlete, they're immediately coming in 2 days after surgery and they're in the AT clinic like busting their butt doing stuff. So I think that would affect the outcome too.
Yeah, exactly.
Yeah. And my whole study, every single article that it looked at, the mean age range was 50 to 60. So
Wow.
Hmm. You see,
it
mine
was
didn't
really,
give too much of an age range, but from
Yes.
how it sounded like there was a lot of old people. Because a lot of, I know young people can have osteoarthritis, all these type of arthritis, but it's just the way it talked about it. And it did, some of it did talk about older populations, but I feel like generally it didn't specify because I think you can just
Yeah.
assume, you think arthritis, you think these conditions, you do kind of go to that extreme. But that's kind of what I was thinking that maybe is why it's so like here and there because there's so many different populations that take the steroids and like, I don't know, some articles I guess just don't differentiate that
Yeah.
difference.
Yeah.
Mm.
So what I'm hearing is overall good for pain, but we don't know if it's good or bad to take. So we're gonna do it by case basis.
Basically, that's what it sounds like. Be like, oh, we could try this. Not long term, but we could try it. Like with everything, it's just if it helps, if it doesn't, we'll figure it out.
I also
yep,
want to know
it's
what long
basically a
term.
good little field.
Yeah, I don't know.
Long term, I mean, mine specifically says that the um the doctors that prescribe the injections, like only 1 in 5 will experience a decrease in pain that's mild, so not even taking the pain all the way away, right? But then it also says it's a short-term quick fix for a long-term problem.
But that's what I'm saying is like, what is their definition of a long term? Like when the articles that we're reading is like, well, don't take it long term. How long is long term? Because like if we think about like you and your like personal stuff, like how long are you going to be taking those injections on your back? Because like to me, long term is like if you're getting one once a year, to me, like 3 to 5 years is long term. So like, what are these articles considering long term? Are you telling me that when I'm 60, I can only take these for like 3 to 5 years? Or are you telling me that I can take them till I die because it doesn't matter?
Yeah.
I don't know.
Yeah, that's kind of what I've been thinking about while like talk back and forth. I'm like, dang, I've been getting these for a good 4 years. What now?
Mm. But also, I think it'd be hard to come off that. I feel like because when your body's used to getting this thing that you're like, oh, this is making me stronger, then even if it didn't have a difference, but like you take it away, like I think like how do you replace something so like invasive like that to like but to be as helpful? You know, like you can do as many bird dogs as you want, but like back pain, like when you get an injection, like I feel like that's a whole other level of like pain relief that I don't know, even if you do get a plateau, like I don't know, just brain is conditioned to associate this with benefiting, even if it doesn't. So I'm like, that just they didn't talk about that. It only went up to like 6 months. I feel like that my article talked about like use, and even then, at 6 months it plateaued, but it didn't tell me how long they looked at that patient after it plateaued. So
Yeah.
I don't know.
Yeah, I mean, y'all have kind of seen me. I'm in tears 1 week and then I'm doing everything y'all can do the next week. So, I mean, in that sense, yeah, it works, it does something. I can move, not in tears. But yeah, I don't know, because mine only goes to 3 months, so couldn't tell you.
Hmm.
No, bro, that's for the physicians to figure it out. It's above my pay grade.
Mm-hmm, mm-hmm,
Of my clinical expertise.
mm-hmm.
That's what I feel like is so funny about off topic. I feel like that's what's funny about like the pharmacology is like I understand that we're learning it so that we have an understanding of like what our patients are going through and so that we can help like explain things that either they didn't ask, the doctor didn't explain, or like also just so we have like a general awareness of like what drugs they're taking. But like how much of this am I really gonna remember? Because like like I'm talking like drug specific. Like obviously I'm gonna remember the laws. Obviously I'm gonna remember like the schedule thing and like the rules and like the story that we heard about what's his name having to become the head AT because his head AT was selling drugs and whatever. Like obviously I remember all that, but like how much am I supposed to be advising these people on whether or not to take steroids? Because I'm basically gonna say what Matt says every time and be like, well, go for it, but don't do it long term. That's gonna be like I feel like the end of my expertise on that. Just gonna call it.
Interesting. So I feel like if I were to like, oh, like what I got from this is that if all else fails, then like I would
Right,
like that's when I feel like I'd refer. But even then, I'd be like, the same thing. I'd be like, you can try it. Like it has these effects. So, like it's not going to be long term, but like it'll help you, I guess, through a season. But then I
right,
feel like in a patient's eyes, they're going to be like, oh, so it's not going to work. Like why even?
right.
Like so I'm broken. You know what I mean? Like
Yeah,
so I don't know how to go about that part of, I guess,
yeah,
educating a patient.
yeah.
Because we read the
Yeah.
articles, we know exactly like what we mean, but to them it's just like basically, oh, so it doesn't work. Like even if it does, like short term in their mind, it's like it's just not going to work. Like who
It's just,
cares?
yeah, I'm just never gonna be better.
Exactly. Yeah.
And, and like my thought process is, well, okay, well, I get this steroid injection. It takes all my pain away. I'm not gonna do PT though. And then it's like,
Right.
okay, but you have a labral tear. Like that quarterback from spring football. You have a labral tear. Of course your pain's coming back. What have you done for it?
It's still torn. It's like,
Oh, we're gonna
But
go
I
get
feel
another
great.
shot and never come back. Okay, okay, okay.
That's
Lovely.
true. Mm-mm.
I will say one of my preceptors, she says this all the time, which I think I'm gonna steal from her. But she's like, she loves to like treat people. Like she puts them on ice, she'll put them on stand, like whatever to make them feel better. But then every single time she's like, I'm just letting you know, like it's not gonna fix anything though. You're gonna walk away, you're still gonna be broken. She said, but your pain's gonna be good for a little bit. She said, but you're still broken. And they like leave. But then they don't have that expectation of like, oh, this is just a like ice is gonna heal my torn tendon and all of a sudden I can walk again. Like, no, not really. So
That's what I do with kids who ask for STEM. I'm like, okay, but can we do something first? Because that's just
mhm.
gonna make you feel better for.
Oh yeah, any modality. I'm like, do these things, do three things. I name three things. I'm like, then we'll do it. Like I promise. And like sometimes if I know that like need like if we're doing quad activation, I'm like, all right, I'm not gonna make you do things. Like we're always trying to activate a muscle. But if it's like pain things, I'm like, I know
Yeah,
there's a part of it that is in their brain that I'm like, all right, we're gonna cup you. Like I want you to do these stretches, and then I will make
yeah,
sure to do that. Like
like
because
earn it.
yeah, exactly, yeah. Like I want you to at least try to activate your muscles. So you just if I just give it to you, they're just gonna associate that with your relief. But I want you to at least have some sort of like, oh, I did these things before, during, after. Like okay, it's a whole multimodal. It's a kinetic chain, one might say.
Yep.
Boy,
No, I do
that's
the
a good
same.
note to end on right there. It's kinetic chain.
It's
Great
all
talk.
a kinetic chain. Perfect.
I think we're good. I think we had a good little talk.
I feel good. Any last comments? Angelica, I think I cut you off with my kinetic chain.
I forgot.
Okay, slay.
Late.
Slay.
Cool. Sounds good.
Sounds good to me.
Perfect.